Good afternoon, and thank you for allowing me the opportunity to present my research proposal today. My name is Andrew Langlois, and this proposal focuses on a practical question facing VA outpatient mental health services. How do we structure care in a way that improves both access and outcomes for veterans? We know access remains a challenge. We know telehealth has expanded rapidly. What we do not fully know is whether a structured hybrid model, one that intentionally combines in-person and video sessions, leads to stronger engagement and symptom improvement rather than traditional in-person care alone. This study is designed to answer that question using a randomized controlled trial within a real VA outpatient setting. This study focuses on a practical issue that directly affects veterans in outpatient mental health care. Many veterans struggle to consistently attend in-person appointments due to transportation challenges, distances from VA facilities, scheduling conflicts, family responsibilities, or provider shortages. These are not minor inconveniences. Over time, missed appointments can disrupt continuity of care, delay symptom improvement, and weaken the therapeutic alliance. Even motivated veterans can fall behind in treatment when structural barriers interfere with attendance. Telehealth has expanded access significantly in recent years. However, the question is not simply whether telehealth works. The more practical question is how to structure it in a way that improves long-term engagement and clinical outcomes. Instead of replacing in-person services, this study evaluates a structured hybrid model to determine whether combining formats improves both symptom outcomes and engagement within a VA outpatient setting. The population for this study includes adult military veterans currently receiving outpatient mental health services through the VA. These veterans may present with PTSD, depression, or related mental health concerns, which are among the most common conditions treated in VA mental health clinics. The focus is intentionally broad because this reflects how outpatient care actually functions. Providers are not treating one diagnosis in isolation. They are treating complex, overlapping concerns. Veterans may present with trauma, mood symptoms, substance use concerns, and family stressors at the same time. This study reflects that reality. All participation would be voluntary, and veterans would receive continued clinical services regardless of group assignment. The goal is to evaluate delivery format, not deny or restrict care. Research shows that veterans continue to face barriers to accessing mental health care. These barriers include long wait times, limited provider availability, transportation issues, and broader system level challenges. Even when services are technically available, structural factors can reduce consistent attendance. It is important to recognize that missed appointments are often interpreted as non-compliance. In many cases, they reflect logistical barriers rather than lack of motivation. When veterans miss sessions, treatment momentum slows. The therapeutic relationship can weaken and progress may stall. Access is not only about availability, it is also about usability and consistency. When veterans cannot consistently attend treatment, symptom improvement becomes harder to sustain. This study focuses on evaluating whether modifying service delivery structure can address some of those barriers without lowering clinical standards. Research comparing telehealth and in-person mental health services shows that telehealth can produce comparable reductions in PTSD and depressive symptoms. That is significant because it demonstrates that telehealth maintains clinical effectiveness in outpatient settings. However, equivalence in system reduction does not automatically mean equivalence in engagement. In practice, many providers use a mix of formats depending on scheduling, availability, and client needs. Hybrid delivery is already occurring informally in many clinics. What is limited in the literature is structured evaluation of a planned hybrid model. Instead of reacting to schedule changes, this study tests whether intentionally alternating formats produce measurable improvements in engagement and symptom change compared to in-person care. Research also shows that telehealth increases service utilization when veterans are provided with video-enabled technology. When technology barriers are removed, participation increases. Additional VA-based research demonstrates expanded mental health service used through video to home telehealth, although engagement may vary across demographic groups. This suggests telehealth improves access but does not automatically equal sustained engagement. The question becomes whether combining telehealth intentionally with in-person sessions strengthens continuity of care rather than replacing one format entirely. A balanced structure may provide flexibility without sacrificing connection. The research question guiding the study asks whether veterans receiving VA outpatient mental health services who are randomly assigned to a structured hybrid telehealth intervention demonstrate greater reductions in PTSD symptoms, depressive symptoms, and improved treatment engagement over 12 weeks compared to veterans receiving in-person care only. This question reflects more than a clinical issue. It reflects a systems-level decision. VA clinics must determine how to allocate resources, schedule providers, and structure care delivery. If outcomes are equal or stronger and engagement improves, that has direct implications for how services are structured in VA outpatient clinics. The independent variable is the structured hybrid telehealth intervention. Veterans in the hybrid group will receive 12 weekly 50-minute psychotherapy sessions over 12 weeks. 6 sessions will be delivered in person, and 6 will be delivered through secure VA telehealth. The comparison group will receive 12 weekly 50-minute in-person sessions only. Both groups receive the same number of sessions, the same duration, and the same standardized treatment protocol. The only difference between groups is the delivery format. This study is not testing different therapies, it is testing the structure. That distinction matters for internal validity and for real-world implementation. PTSD symptom severity will be measured using the PCL-5. Depressive symptoms will be measured using the PHQ-9. Both instruments are validated, widely used in VA settings, and appropriate for repeated measurement over time. Using standardized tools allows for objective comparison between groups and reduces reliance on subjective impressions of improvement. Assessments will occur at baseline, 6 weeks, and 12 weeks. This repeated measurement allows for evaluations of symptom trajectory rather than relying on a single before and after comparison. Treatment engagement will be measured through session completing rates pulled from clinic records and a brief self-report engagement scale. Measuring both attendance and perceived engagement strengthens the overall measurement approach. There are 3 directional hypotheses. First, veterans in the hybrid group will demonstrate greater reductions in PTSD symptoms over 12 weeks compared to the in-person group. Second, veterans in the hybrid group will demonstrate greater reductions in depressive symptoms. And third, veterans in the hybrid group will demonstrate higher treatment engagement. These hypotheses are based on practical assumption. When access barriers decrease, consistency increases. When consistency increases, exposure to treatment increases. When exposure increases, symptom improvement becomes more likely. This study tests whether the sequence holds true within a VA outpatient setting. This study uses a randomized controlled trial design. 80 veterans will be enrolled and randomly assigned to either the hybrid group or the in-person group, with 40 participants in each condition. Random assignment reduces selection bias and strengthens internal validity. It increases confidence that outcome differences are related to delivery format rather than pre-existing differences between participants. Both groups will receive 12 sessions over 12 weeks. Outcomes would be measured at baseline, midpoint, and post-intervention. Measuring at multiple time points strengthens the ability to detect patterns of change rather than relying on a single comparison point. The study will use a non-probability convenience sample drawn from a VA outpatient mental health clinic. Eligible veterans who meet inclusion criteria and provide informed consent will be enrolled until the target of 80 participants is reached. While convenience sampling limits broad generalizability, it reflects how research is often conducted in clinical environments. The goal is feasibility within a working VA clinic. Because participants are already engaged in outpatient services, the sample reflects a population most likely to experience the practical benefits or limitations of structured delivery changes. Participants will be recruited through VA provider referrals and clinic-based outreach. Participation will be voluntary and will not affect clinical services. Veterans will be clearly informed that declining participation will not change the treatment plan. Retention strategies include appointment reminders, flexible telehealth scheduling, and follow-up contact after missed sessions. Because engagement is one of the dependent variables, minimizing attrition is critical. High dropout rates would weaken internal validity and limit interpretation of outcome differences between groups. Data will be collected at 3 time points: baseline, 6 weeks, and 12 weeks. Standardized symptom assessments and electronic attendance records will be used consistently across both groups. Collecting data at baseline allows for group comparison prior to intervention. Midpoint data provides insight into early change patterns. Post-intervention data allows for evaluation of overall effectiveness. This repeated measure structure strengthens the analytical power of the study and improves confidence in interpreting change over time. All participants will provide informed consent, and confidentiality will be maintained in accordance with VA and federal regulations. Institutional Review Board approval will be required prior to implementation. This ensures ethical oversight and protection of participant rights. Random assignment, standardized treatment protocols, and repeated outcome measurement strengthen study validity and research quality. These elements reduce bias, increase reliability, and support conclusions regarding the effectiveness of the hybrid model. In closing, this proposal is not about choosing telehealth over in-person care. It is about testing how to combine both in a way that improves consistency, engagement, and clinical outcomes. If the structured hybrid model demonstrates improved engagement and comparable or stronger symptom reduction, it provides evidence to guide how VA outpatient services are organized moving forward. It could influence scheduling practices, telehealth allocation, and provider workload distribution. The broader goal is simple: improve access, improve engagement, and improve outcomes. For veterans receiving outpatient mental health services, service delivery structure matters. The study aims to provide data that helps inform these decisions. I'd like to thank you for your time and thank you for your consideration in this research proposal.